Hello, my name is Alexander Cherkashin, and I'm talking today about preoperative planning for limb deformity correction with external fixation to share some tips, tricks, and some of the secrets. Here's my disclosures. We developed the TrueLock external fixation system, which Orthofix distributes and for which we get royalty. But more importantly, I'll share with you my experience and my most favorite toys. I'm working at Scottish Rite Hospital for Children in Dallas, Texas, USA. We are working in the Center for Excellence in Limb Length and Reconstruction. This is quite a fine group where we develop new techniques, new methods, and sometimes new devices to use with limb length and deformity correction. Before that, until 1995, for 12 years, I was working in Elizarov Center in Kurgan, Russia, where I had opportunity to learn directly from Elizarov, and I was there the head of the Department of Hip Pathology. Now, why preoperative planning? Why do we need it? I refer to a very smart man, I think, Winston Churchill, and that's what he said. Those who plan do better than those who do not plan, even though they rarely stick to their plan. And I completely agree with him. Also, when we do preoperative planning, it helps us to deal with complication. When you have a plan, you know when plan is not working, and this is the time to interfere. Anyway, preoperative planning for external fixation. What do we plan? You can think about this talk as a little summary of what you already learned and maybe a little bit what you will discover in the next days. So, talking about deformity correction, yes, that's what we plan. We plan to correct deformity. How to do it? And for this, we need first, where to locate the hinge or hinges to do the correction. Where we will do osteotomy or osteotomies. At which level? How we assemble and mount the external fixation frame on the patient. And finally, what's the rate of correction? So I'll concentrate mostly on hinge and osteotomy levels in this talk, but we touch on some other points here too. Let's start with the hinge. How do we find that hinge? But that's exactly why you're here. This is why you go for deformity correction courses here in Hull, Baltimore, or anywhere else. You read the books about deformity correction. You start with deformity analysis. Draw the axis of the fragment, find where they intersect. This is your deformity apex. Draw bisector line, position the hinge depending of amount of shortening, lengthening, or translation. And how you can do it? You can do different tools. Nothing wrong with still use, old pencil and draw it all on the printed x-rays. But you have to print the x-rays. Now, in the digital technology era, of course you can use the computer assistance. Almost every PAC system, every radiology system gives you ability to draw lines, measure angle. It's available in most hospitals. Unfortunately, it's always single plane planning. You're doing it on one plane. You have limited ability to cut a line segment. Some systems don't even give you this ability. You can plan really for external fixation. So overall, it's quite clumsy planning. Now, there is a very good software, TraumaCut, which actually very enhanced planning. It's separate subscription software. You can do planning and you have templates for different multiple hardware options. Unfortunately, you're still planning only in one plane. You can do two planes, but they're not connected to each other. And it's expensive software to do. Now, one of my favorites is the app Bone Ninja. This is the iPad app. It's very simple and affordable. You just draw lines where they intersect. It presents the angle. You can cut and reposition the parts of the image, part of the X-ray. They have very nice built-in examples so you can learn. Now, it's only iPad. So if you don't have iPad, you're out of luck. And again, you're only doing planning at one plane at a time. They're not related to each other. So if you have oblique plane deformity, that's really difficult to comprehend. And finally, obviously my favorite, is Hexray. I sometimes call it Bone Ninja on steroids. This is integrated model of TLHex software, but you can use it just for analysis of deformity on any x-rays. It gives you precise measurements of deformity parameter, the evaluation of your mounting parameter, and you can check and adjust your correction. Now, talking about external fixation, you need to be sure you choose a proper instrument, because there are two types of hinges. There are frames with physical hinge and there are frames with virtual hinge. Physical hinge, can be just one hinge like a monolateral system. It can be coupled of aligned hinges like in majority of circular systems. Now, one thing too important, they always work only in one plane. You can correct multi-plane deformities if you position the hinge, reposition the hinge for each plane separately. Or if it's same level, oblique plane deformity, you need to find the positioning. It's very, very important. The virtual hinge, physical hinge requires very precise, I would say crazy placement. And this is, I call it, crazy way of dealing with the hinge. If you didn't position your hinge correctly, you best way will not correct deformity completely, or you actually can create secondary deformity. And this brings us to the virtual hinge. This is the hinge of hexapod systems. You don't see it. There's no hinge. There are 6 struts. But those struts work around virtual hinge. Now, that allows you to do simultaneous or parallel correction on multiple planes. You can correct angulation, translation, and rotation simultaneously because your hinge is anywhere in the place, in the space. It's aligned anywhere you want to do it. So, you need software. So, virtual hinge is calculated and adjusted by software. So, you don't see this hinge, but it's there. And this is why I call it a lazy way of dealing with the hinge. Let's look at a couple examples. This is the physical hinge frame. And we will use the tibial deformity correction as an example. This is a so-called true-lock frame. This is the true-lock system which we use, which is based on original Elizarov fixator. We just modified some hinges, I think, and some destructors for, I believe, a little bit friendly use for the surgeons. Let's look at this 12-year-old girl with infantile Blount's disease. She was treated many times before. Unfortunately, she still has deformity and even some hardware retained with quite significant bony overgrowth. So you can imagine it's a challenging situation. Now, if you start the planning, again, I'm just showing you example with X-ray software planning. You can do it with a pencil and pen. So in the X-ray, you basically draw axis of 2, 3, or whatever segments. So this is the proximal segment, distal segment. Proximal segment is pretty short, so you use joint orientation line. And you don't even need to intersect the lines because software know where those lines intersect. So they intersect here. So this is your apex of deformity. By the time you already know that your apex of deformity outside of the bone, it's probably not one deformity. This is something more complicated. But let's say if we position the osteotomy here, because we're using X-fix, we need some stabilization, proximal and distal, enough room to put rings. And if we draw osteotomy line here, the software tells you if your line is here, you will need to translate the osteotomy site for 31 millimeters. We can just graphically represent and see what happens. This is how it will happen. If you align everything to 0 parameters, no deformities, you will have a huge amount of translation. So obviously it tells you you probably won't be able to successfully correct this deformity at only one level. So you can do more complicated planning. So you align proximal segment with the middle segment first, and then you align middle segment with the distal one. So this is your 2-level correction, and that's give you proper alignment and not a lot of translation. Obviously, we need quite a bit of lengthening to avoid the fragments impingement for this girl. So we decided to do the correction simultaneously of both of her legs, but we also decided we will do it gradually. We do proximal correction first on 2 legs, and then we come back to second osteotomy for distal correction and additional lengthening. and we done our preoperative planning. We pre-assembled our frame. So this is made surgery. I'm doing the drawings on the extremity, and here's the pre-assembled frame. Yeah, I wouldn't say it's crazy. Pre-assemble the frame with 2 sets of hinges, and this is what we do. You can see on this frame, this is your first set of hinges for the proximal correction. This is second set of hinges, one angle distractor, second angle distractor. So we prepared this frame, we pre-built it. Now, this is one of the first secret. This is the beauty of pre-built frame. You can use it as a template for your pin and wires placement. So you can be more precise in positioning and placing your frame. And that's exactly what we do. You can see the frame positioned on the extremity, with a proximal set of hinges, distal set of hinges aligned exactly where you want it. Now, the first step, we just done the proximal osteotomies. So this is end of the first surgery on both extremities. Again, you can see the 2 sets of hinges, proximal hinges aligned here, distal hinges. One angle distractor, second angle distractor. We start your correction here. So this is here at the middle of correction. The beauty is it's very stable frame. Majority of external fixation frame allow patient to full weight bearing. That's what she was doing during the treatments. This is her end of correction. It's unmasked distal valgus, the result of previous treatment, previous correction of the varus. And now we took her back to the surgery. We temporarily disconnect the second set of hinges and done the osteotomy, distal osteotomy, reconnect the hinges, and here her end of the second correction. You can appreciate nice, perfect alignment of both tibias. And that was done exactly according to our plan. So here's her outcome, nice, straight legs, good alignment. That's the end of the treatment. So now let's do the example of the virtual hinge. Again, we use tibial deformity correction. We will use the planning on the tibia. Now, even if you're dealing with a lazy hinge, there is still 2 ways to deal with the lazy hinge. There is a lazy way, or sometimes called ring first method. In this case, you apply the external fixator first, and you think later. I'm just kidding. What you do, you still need to think, you still need to plan what you're doing, but what you do, you do not pre-assemble your frame, you go ring by ring. So you apply your frame and you go to the Hexapod software and enter deformity parameters and mounting parameters after surgery. And there is a crazy way to deal with a lazy hinge. This is preoperative planning method. So the difference here, you start your planning, start thinking first, you calculate deformity parameters and pre-build your frame. And you take this pre-built frame, take it to surgery and apply it. So it gives you better options for precise correction. So you apply pre-built external fixation. This is the crazy way. So let's take a look how it works on this 14 years old with adolescent Blount disease and 1.5 centimeter shortening. This is one of our typical Texas size patient. You can see there's amount of deformity, maybe not that big, but the patient is huge. He is more than 250 kilograms in weight. So here his preoperative x-rays. We downloaded those x-rays into the software and we start deformity analysis. You can see the proximal axis of the segment. Again, we use the joint orientation line to position this axis, and this is distal axis, and this is where those axes intersect. This is your apex of deformity. You can see deformity apex on AP, and on the lateral they are approximately on the same level. It's just oblique plane deformity. And as soon as you draw this line, software calculates your deformity parameters. It presents you with 25 degrees of varus, 20 degrees of procurvatum. And you have to enter rotation deformity manually. You cannot really analyze it on X-ray. So we know that this patient has 15 degrees of internal rotation. And this is what we entered here. Now, as soon as we draw the osteotomy line, software calculates the amount of necessary translation. You see, our apex of deformity is not where we're planning to cut the bone. Sometimes we refer to it as osteotomy rule 2, correct? So we know if we cut the bone here and we want to align both axes, we will have to translate distal segment a little bit more laterally. So this is why software tells you that you, at this point, you have 11 millimeters of medial translation. You can better understand when you go to the next step and see how the correction works. So this is your perfect alignment, and this is the translation. So you can play with the software, moving your osteotomy line back and forth until you're satisfied with the amount of bone real estate where you can position your supports and the alignment at the end of correction. So now when we're happy with the alignment, we need to decide how much lengthening we need to do. And this is we just entered as a simple amount. We know that he has 15 millimeters of shortening, so we will do 15 millimeters of lengthening. So software will position the virtual hinge away on the lateral side of the bone to achieve this necessary lengthening. So, and finally, before we go to surgery, we use software to help us design the frame. We need to know the size of the supports we're using. You can use templates, we can use real rings, and you should measure it on the patient. So we measured the rings on the patient, and we realized we need 280 millimeters proximal ring. That's 280 millimeters internal diameter. It's big. And we also need 200 millimeters second ring there. And then software allows us to position this ring right on the patient. When we start positioning the ring, we realized even 280 millimeter ring still can impinge posteriorly. So we decided to switch from the full ring to the 5/8 ring to give a little bit more room for this bulk of the tissues. So this is our position on the frame, and software calculates the position of the frame and give us the struts. But the beauty is, so you can use software to help you with the strut management. You know, when you do deformity correction, you can end up with changing or adjusting the struts. So software allows you to play a little bit with those parameters and tells you, so if you position ring on this here and you want to correct this deformity, you have to change strut number 6 one time and then adjust the position of the strut, of length of the struts a little bit later on. But we can play with it. We can take the distal ring, because this position is not really set. You can move it higher up proximal or distal, and playing with this, you can avoid the strut change. You just save yourself the price on one strut. And then what's nice, you can also use the software to help position the frame precisely where you plan it to. Sorry, this is X-ray for the different patient, but it doesn't really matter. What you do, you can click on the orientation line, and software position the line on the X-ray, and you can find something which you can easily identify in surgery with CR, for example, the joint line. And as you position this orientation line, software calculates the distance from this line to the ring and distance from this line to the osteotomy, which gives you opportunity to very nice placement of the surgery. You can print this parameters and take it to the surgery. So this is your printed report, your line, your position of the ring, reference the proximal ring of the frame, and the distance to the osteotomy. So this is your software preoperative planning. This is your pre-built frame according to software. It's very nice. You bring it to surgery and you align it on the patient again. As we discussed, you use it as a template for pins and wire placement. This is the frame applied. At the end of the surgery, you can appreciate it mimics all the deformity of the patient. You can see the procuratum, you can see the varus deformity. And then you take your postoperative x-rays. You take this postoperative x-rays, download into the software. So you go back to the software, go to your mounting parameters, click X-ray, and switch to the postoperative planning. This is the only one disadvantage, if you call it disadvantage, of preoperative planning, of the crazy planning way with a hex support system. You have to adjust, you have to do your planning on X-ray second time after surgery, because no matter how good you try, you always do a little bit different positioning of the frame than you planned before. So this is postoperative X-rays downloaded in the software. You mark your osteotomy lines and you realign your deformity axis. The software will bring the exactly same deformity as you planned before, but it might not exactly match with your postoperative X-ray. Why does this happen? Why deformity may be different on postoperative X-ray? Of course, if you've done some acute correction, it may be different, but there is a different reason. The reason is it's very dependent on how the X-ray are taken. Until you start to do digital planning on X-rays, you don't really realize how dependent we are on the quality and position of X-ray. I'll show you an example. So this is just a saw bone, and this is the projection of saw bone. Imagine this is the X-ray of this saw bone. So if you do X-ray in this position, it's one angle. You move a little bit, it's a different angle. Look, you move a little bit, you can don't see angle at all. It looks like a straight bone. So if your postoperative X-ray are positioned differently from your preoperative, you can expect that your lines will not match. So you have to decide which one you trust more and use those parameters. Then software allows you to put your virtual ring. Again, the ring may not match. First of all, the frame can be shifted, not exactly positioned as you plan, because you apply preoperative values. And also software assumes that X-rays are done in the plane of the proximal segment or reference segment. In this case, it's proximal segment. So it thinks that X-ray beam is exactly perpendicular for the proximal segment, which is not true here. Unfortunately, you can use ability to unsync the rings and do position the rings according to the positioning of the patient on each X-ray on the MP and lateral, and you can bring it to very, very close match. This is your opportunity to see how it's looking. So here's your mounting parameters. Software calculate where is the center of the ring and the orientation of the ring relative to the axis of your reference segment. Why it's important? Remember, there is still a hinge. You don't see the hinge. It's a virtual hinge. And software depends on your mounting parameters to calculate where this virtual hinge will be on the frame. So this is end of your postoperative calculations. So you go back to your postoperative parameters, and software gives you prescription how to correct this deformity. So patient will be adjusting the length of the struts in order to do the deformity correction. So this is patient in the process of the correction. This is end of the correction. This is consolidation period, and this is patient walking on the frame. Even there is huge external fixation frame with 280 millimeter ring. It's still a stable construct, allows full weight bearing. Actually, we require full weight bearing to all the patients to be sure they are functional, and it provides better consolidation. This is the at the frame removal, and this is the 1.5 years after frame removal. You can see the patient didn't lose any weight, but he has nice, very well aligned extremities. So here's the crazy way of planning the lazy hinge. So preoperative planning gives you ability to calculate struts and rings placement by software. It will definitely save you time and error. It will be more efficient frame. You'll have less strut changes and adjustment. It's easier to align, and it's easier to play because you use your frame as a template, so you can see where pins and wires go. Even though you go postoperatively to adjust your mounting parameters, but there's much less parameters to enter and deal with. You have more precise measurements, and you can avoid hardware interference, because if you cannot build this frame, software will not let you. But if you put ring first, you can be in a situation where you can have huge difference by positioning or adjusting the struts. So this is about the hinge, physical virtual hinge. Now let's talk a little bit about osteotomy levels. And again, I'll bring this example of this little 3.5-year-old girl, which was unfortunately involved in the car accident and resulted in a distal tibial fracture, with intensive damage of the soft tissue. She underwent the spanning fixator placement and the flap to cover the defect of the soft tissue. We also can appreciate, absolutely sure, there is some gross plate damage. So 4.5, when she became 4.5, we see already the result of the gross plate damage and development of the valgus deformity. We decided to attempt the bar resection. unfortunately it didn't work that good, and she also deformed some adduction deformity of her foot because of the damage of the tissues. So we took her for the mid-foot osteotomy. I corrected the deformity. We also did contralateral proximal tibial epiphysiodesis to deal with the length discrepancy. So let's move on. So she is 12 years old now, and she developed this severe valgus deformity, ankle contracture. She also have quite a bit of external rotation. So this is what we have to deal with. This is just close-up X-ray of ankle joint to appreciate huge deformity at the joint line. I mean, arthritic changes, calcaneal position of her foot as a result of recurvatum deformity on the distal end of the tibia. So we decided we need to deal with this with a gradual correction with precise alignment with external fixator. But we did preoperative plan in the pre-built bed frame. But what if we decided to go lazy way and do ring first? Let's do the scenario. So I'll probably position the distal support somewhere here, parallel to her joint, right? I will probably put second one somewhere in the middle, maybe have a ring block. And then to be careful, I'll probably do the cut much away from the distal ring to be sure that my osteotomy will not propagate in the pin sides. So seems like a reasonable plan. I have fragment, I have osteotomy. Now I put my fixator again. It just simulated because we didn't deal this way. So this is simulation done through the X-ray software. You can see position of my ring and osteotomy. Now, in order to align those supports, I should rotate right around the apex of deformity. So software put the virtual hinge here, and when it does, with the level of osteotomy here, this will be my correction. Oops. What do you think the chances of this translation osteotomy site to heal? But even if it would heal, can you imagine how big the bump here inside the soft tissues on the skinny girl, how much translation you have to do here through this compromised soft tissue? That's definitely not the way to go. So we fortunately done preoperative planning for her. So we have our axis lines, distal segment axis, proximal segment axis, our apex of deformity, but then we start playing with positioning and playing with the osteotomy. So what I did here, I did my osteotomy not perpendicular to the bone, but obliquely. First of all, it gives me a little bit more room on my distal segment to position wires and maybe even insert 1/2 pin. But it also give me opportunity in much better alignment of the segment at osteotomy side. Remember, the rotation parameters you have to enter manually. She has 20 degrees of external rotation. So this is my correction plan. Now I have much better relationship at the osteotomy side compared to doing transverse cut through the bone. And that's what we decided to do. Secondly, we go to the frame planning, and here's positioning of my ring, give me enough room for a couple of wires, but it also shows that the segment is very small, and maybe I'll probably not be able to put the half pins here, so which means it's probably not a bad idea to extend your frame to the foot and have a foot and distal fragment as a one block for better stabilization. And that's what we decided to do. So this is my preoperative planning. This is the printout of my preoperative plan, which I took to surgery. This is the joint line. This is the osteotomy line. Not a lot of room to work in. And here's another secret. We already talked a little bit about it, but it's a very good idea. Do your planning and then draw your planning on the patient leg. That's exactly what we done. We draw the planning of the leg. Now, because osteotomy is very close to the pin sides, we decided to do jiggly saw cut. It's actually pretty nice osteotomy with jiggly saw. So we pass the jiggly saw before applying the frame. It's difficult to pass the saw through the frame. And then here's our pre-assembled frame and our drawing. You see the joint line, osteotomy line, the center of the ring, and we're using the frame as a template. So we positioned our frame, we take our pass jiggly saw, which passed before, and we do the cut exactly according to our preoperative planning. It's a good idea to use jiggly saw, it will not propagate into the pin side. So we are able to put only 2 wires, and then we extended the frame. We use the foot plate and put wires of the foot connected together and using as one block. We also position proximal support. This is for the second stage, and the same frame will do the proximal osteotomy for tibial lengthening. We don't want to do a lot of lengthening. She has about 3.5 centimeters of shortening, so we do some lengthening, about centimeter here, but we still have quite a bit of lengthening to equalize the deformity, so we'll do it proximally. So this is our postoperative X-ray. You can see the level of osteotomies, and we downloaded X-ray, and we done our reference ring, postoperative reference ring matching. You can appreciate the position of the rings. And this is our postoperative X-rays. And this is our correction. Again, everything going according to the plan. Nice, good alignment. So you see, this is the nice weight-bearing frame. To help your weight bearer, we put additional rails so she can weight bear in the frame, even she cannot put the foot on the floor because of the foot frame. And then we took her to surgery. I can compare actually the correction of distal tibial. Took her to surgery, done our proximal osteotomy, reposition the ring, connect it with struts, and do the lengthening. Take a look on the regenerate. That's a beautiful destruction regenerate. This is the one you want to do, and the reason is because at the end of correction, at the end of lengthening, we switch from the 6 strut to dynamization models. The dynamization models allows axial motion, axial micromotion, giving you very, very good loading and good development of regenerate. So here's your complete correction. Sorry, here's her walking in the frame. You can see she can full weight bear. By the way, when we done the osteotomy for lengthening, we remove her foot plate, and the proximal osteotomy allows better blood supply for the distal end, and overall time in the frame is actually less than doing it sequentially and waiting for consolidation distally. So this is your X-rays at the frame on removal. You can see nice alignment in both planes, and this is her amount of motion. Unfortunately, we're not able to increase her motion, but we put it much more functional plane. One little example on when you want to use your lazy way to deal with a lazy hinge in hexapod systems. So when you use ring first, this is usually happens when you do some acute correction at surgery. This is 15-year-old girl. She sustained a proximal tibial fracture, but unfortunately developed a compartment syndrome, has some fasciotomies, and as a result of compartment syndrome, she had a bad equinus contracture of her foot. This is how she was walking on weight bearing. It's absolutely rigid, not moving. So we decided to do the correction through the soft tissues, and we want to do as much acute correction, and if not possible to correctly acute everything, we'll do the frame. So we took her to surgery, done plantar fascia release, tendon Achilles lengthening. We were able to achieve some correction, and obviously it's not that rigid anymore, but not enough for her to function, so the rest will be corrected with the hexapod frame, gradually correcting through the joint. So we're doing ring first. We apply the foot support using foot longitudinal wires for better grab of the foot, then additional wires through the metatarsals, then we put the support on the tibia using oblique divergent position of the half pins for better stabilization, one support, and connect it with the struts. Now here's one very important thing. When you're connecting struts without preoperative planning, you have to understand how those struts will be moving. So you want to give maximum threaded rod for the patient to do the compression anteriorly, because the struts will be shortening, and minimum threaded rod to lengthen posteriorly, because the struts will be lengthening. So this is the disadvantage of not using preoperative planning. You now have to think how to deal with struts. Otherwise, you have to change the struts very often, or maybe like on second day of the correction, beginning of the correction. So this is the frame assembled. This is postoperative X-rays. You go and download it to the software. Now you use your osteotomy line through the joint. So your joint is kind of like osteotomy. This is where you we'll be doing the correction. And this is the deformity analysis showing that we still have 33 degrees of equinus to correct. And when you preview a correction, you also want to apply some destruction through the joint to be sure that you not jam the joint surfaces. So this is your mounting parameters. Again, software position the ring perpendicular to each segment, assuming x-rays are done correctly, but you can adjust the position of supports to match it. And it's very important because based on the mounting parameters, software calculate the position of the virtual hinge. So this is the ring matching after the surgery. This is your mounting parameters used to calculate the position of the hinge. This is your correction parameters. You decide when to start correction, how often you'll be doing at what time, how fast you'll be doing, and you can see all the parameters in relation. Doing 0.3 millimeters a day will give you 1 degree of correction, and you have 37 days total to do your correction. This is the prescription of the patient, how many clicks do on the struts to change their lengths, and this is the patient during the correction. This is your precise alignment at the end of correction with joint destruction. After we finish the correction, we actually put the hinge on the system just to be sure that the patient can exercise while the joint is destructed. And as a surprise, we see her active motion is still preserved, so she can use it. This is the removal of the frame. This is her outcome, and this is her walking after the surgery. This is about 1.5 years after frame removal. So here's my conclusion. Do preoperative plan. This is why you're here. The less as you experience, the more detailed should be your preoperative plan. It's not a bad idea if you can to pre-build your frame and use it as your alignment template. Draw your plan on the patient after you've done it on the computer, on the paper, and follow your plan to correct the problems properly. You can see when they arise. So if you fail to plan, you're definitely planning to fail. This is from the Benjamin Franklin. This is the guy on $100 bill. He was a smart guy. So this is all I have for you. Thank you very much. Goodbye.